Welcome, everybody. Welcome to this edition of Ramblings of an Old Fart podcast. Hello, my name is Craig Warren. I'm 71 years old. Been married almost 53 years. Father of 9 and grandpa to a bunch. I'm sort of retired. I retired at 65 to provide full-time care for my wife, who's had some serious health issues. But lately I realized that I needed something to do to keep my mind active. So why not a podcast? I have a lot of experience. I've done a lot of things in my 50-plus years in the workforce, in the workplace. I definitely have a lot of opinions. So what more would I need? I should mention that I have never been a member of a political party, and I do not intend to do so. My podcasts do not come from a political place, but just a common sense and factual place. We talk a lot about modern medicine these days with the robots and the lasers and the miracle drugs and all the other stuff. But today I want to talk about the low-tech side of it, a hole in the system that's actually putting lives at risk. It's the gap between the specialist and your primary care doctor. Some people call it the care fragmentation, but you probably know it as the right hand doesn't know what the left hand is doing. As I mentioned in my intro, my wife's had some pretty serious health issues over the years, and so I know about a lot of this stuff. I will give you some examples that I have seen personally in this area. But first, I want to give you some idea of how big a problem this is. Research into the American healthcare system highlights a few startling statistics regarding this gap. Studies have shown that roughly 25 to 50% of PCPs, primary care physicians, are unaware of what happens during their patients' specialist visits. Communication just isn't there. In many systems, the referral loop, they call it, the specialist sending the report back to the primary care, that's the way it's supposed to work. The problem is it's only completed about half the time. So when you go back to see your primary care, he hasn't got a clue what happened with your specialist. That's an issue. Nearly 20% of patients experience an adverse event within 3 weeks of leaving a hospital after a surgery or a procedure. And the vast majority of these are related to medication changes that weren't properly reconciled or monitored by the follow-up with their PCP. I have a story about that. This is about 2020, I think it was. My wife had to go in for a thoracic surgery. She'd had one in about 2011 or 2012 to remove some cancer. They thought they got it all, but it had come back, so they had to do another surgery. Everything went good as far as the surgery, but after the surgery, during the time when they were getting ready to discharge her, I was there when the surgeon came in to give her final instructions. As part of this, all that led up to this surgery too, she was always also starting to have some problems with AFib. And so they put her on a medication to control the AFib. They didn't want to have any kind of a heart event where she might have to have her heart shocked, you know what I mean? You know how they do to get your heart back in rhythm? They didn't want to have any of that happen until her scars or surgery had healed up. So anyway, but he said the dosage is really high, but she cannot be on that for more than 2 weeks. So you need to get into your primary care within that 2-week period, and that he would make sure that he sent all of the instructions, put it all in her file so that he would know when she got there what he had to do and what kind of a dosage that he probably would have to set her up on. So we got there at our primary care about the 11 days in, I think it was. And so we went through the process. The nurses come in, they weigh her, they do her blood pressure, all the normal everyday stuff. So when their doctor got there, he asked her how she's doing, how she's feeling. She said, I'm doing okay and all that stuff. He checked the incision to make sure it was healing up good, all that stuff. And then he said, okay, I should probably see you again in 30 days. Well, I had to stop. He started walking out the office, and I just had to stop him. I said, well, wait a minute. Did you read the file? I said, when we left there, the surgeon said that she could not be on this, whatever the drug was. I can't remember what the name of it was. But she couldn't be on that for more than 2 weeks because it was dangerous at that high a level. And that you were supposed to have all the information to reduce that drug or do whatever needed to be done so that she wouldn't have a problem. She says, oh, well, let me check. So he gets in his computer and checks, and takes him a couple minutes. Oh, you're right. Good catch, man. That's what he said to me. Good catch. That's not what you want to hear from your primary care, right? Not on something that serious. So, but my catch at my PCP, my wife's primary care office, it's a vital issue, but, it's because the safety net often fails due to these structural issues, right? The problem we have in a lot of this is we have our primary carers. Physicians are really, really busy. They might receive dozens of digital files every day with specific instructions from specialists and other things, tests that come in. The problem is, like on my wife's, I don't know how far she had to go down into that report from the surgeon to find it. But it might be buried down 15, 20 pages deep, in some kind of a summary. It could easily be missed. I think there's some changes that have to be there, but that's the issue we have. They kind of get overloaded, and they sometimes don't spend the time before the patient gets there to check it all out. But even today, many hospital systems use software that doesn't talk with the software in the primary care's office. So then their office has to log into a separate website to get the information. That's a system that's not a good system either. We're going to talk about that more in a little bit. And then we have the captain of the ship dilemma, I guess is the best way to say it. In the past, the primary care physician was basically the captain of the ship in a way. He sort of was the director of all of the care. But with the rise of the hospitalists and specialized clinics and all this other stuff, sometimes it's unclear who actually is legally or practically responsible for owning the patient's medication lists or any of this stuff, right? I know who owns our patient list because we do. I created one in a spreadsheet. We keep it updated, and we take a copy with us everywhere we go. I'll talk about that more in a minute, too. Most of us assume that because the doctors use computers that they're all looking at the same screen. But they aren't. We've created these digital silos, if you will. A surgeon can change a life-saving medication in the hospital, but if that note's buried on page 15, or if it's on a totally different system, or the doctor didn't receive a ping, like for an email note about some of this stuff, it actually doesn't exist. If he can't see it, it doesn't exist, kind of. So the data is there, technically, but the communication isn't. Information's no good if you don't know where to find it. The statistics are staggering, though, in the research. It shows that nearly 1 out of every 5 patients suffer some kind of harm within 3 weeks of leaving the hospital. Why? It's because 60% of all medical errors happen during that transition of care period. That's the moment you walk out of the hospital and try to resume your life at home. If you think the system is watching your back, the math said it's only watching about half the time. A major 2026 systemic review found that poor communication contributes to 25% of all patient safety incidences. And it's in about 10% of all cases. In 10% of the cases, that was the only issue, was just the communication part. According to the 2025 Candelo benchmarking report, communication failures now factor into about 40% of all medical malpractice claims. This is actually increased over the last decade quite a bit. And you would think, with all the technology and the portals and all the information on computers, that would be getting better. But it is not. The Joint Commission, the organization that accredits hospitals, has consistently found that 80% of serious medical errors are the result of communication during handoffs. The exact system we had with my wife. That's where the system most often breaks down. Okay, so research shows that 80% of all medication errors happen during that transition time. 1 in 5 patients, between 19 and 23%, experience an adverse event within 3 weeks of leaving the hospital. 61% of those are considered preventable with better communication. In some studies, nearly half of patients, 49%, experience at least one medical error in the days following discharge, often because of instructions from the hospital didn't reach their primary care in the time that it was supposed to. You know, they were buried in there, but they didn't get there before in time for the doctor to see them. I'll give you another example of my wife on this. She had another procedure here, heart with her AFib situation. They did a what do they call these, laparoscopic surgery, laparoscopic. I think whatever. They go up through the major vein in your groin, and they did an implant thing in her heart. I don't know all the details, but when we get done, everything turned out fine. She was doing okay. So when they got to the point where they're going to discharge her, they went through all the paperwork and all the stuff. And then they said, okay, you're good to go. But my question to them was, okay, she had to quit taking all of her drugs, or except for 1 or 2, before this surgery. And they said after the surgery, then they would let her know which drugs that she needed to go back on and which ones that possibly she could not take anymore. And also some of the new ones that she might have to take, or at least, for a temporary period of time. I said, so nobody has said anything about what she's supposed to take. So what do we do here? Well, she said, well, you'll have to go see your cardiologist. I said, well, they've already set up an appointment with their cardiologist, but it is 10 days out. You mean she's supposed to go home from the hospital with absolutely no medication for 10 days? So that stopped them think a little bit, And so then it took us, they said, okay, we're going to find out. We'll get into it. So we ended up waiting there, just sitting there in that room for probably 3 or 3.5 hours before they finally got the answer and got us a list of what she was supposed to be taking and when. So those are the problems that we have. The surgeon, he hands it to somebody else, and they don't really know the whole story. Not a very good system. Another that could have been a very dangerous thing if hadn't I not questioned them, right? Okay, so even when the doctor is staring at a computer, the data often isn't there. For instance, about 41% of patients are just discharged from the hospital or some surgery center or something, but there's still lab or test results that are still pending. Of those, nearly 1 in 10 are results that require their primary care to take immediate action, yet the primary care hasn't seen them yet. That's an issue. This care fragmentation I've been talking about is estimated to cost the U.S. healthcare system billions of dollars annually. But for the patient, the cost is time and stress and probably even injury in some cases. One report noted that communication issues are the leading subject of patients' complaints, accounting for 17% of all grievances. It's a big issue. I know this from personal experience. The scariest statistic that I know of is it says 93% of patients say they clearly understood their medications when they left the hospital, yet 39% of those same patients have a medication error within the first 7 days. That's a communication thing there somewhere. This is where I've been able to help my wife because I try and always make sure I'm in there. Somebody just comes out of surgery. They've been on drugs. They've been on anesthesia. They're not always completely thinking clearly at that point. They always need somebody needs to be there, extra set of ears and eyes to see what's going on and hear the instructions to make sure that things are taken care of properly. There's been at least 3 or 4 instances like this where if I hadn't been there, I'm not sure what would have happened. Okay, so who is the real safety net? In my experience, it's not the software. It's not the doctor sitting in the room or the nurse. It's the person in the chair sitting next to the patient, like me, a spouse, a child, a good friend, somebody that's willing to go in and listen and hold out and make sure that they know what's going on. Somebody's willing to say, hey, hold up a minute, doc. I think you're missing something. When the system fails to ping the doctor, the patient advocate has to be the ping. That's me in most cases, in a lot of cases. You have to be their EHR, their emergency human resource, I guess, if you want to call it that. If you aren't checking the medication, the medication administration record, the AMR, or bring a one-page summary to the follow-up, you're gambling with the system that has a documented 40% failure rate. I have to tell you, that's what we do. Like I told you, I created a spreadsheet for her medications, and we have a system in place where we bring a one-page summary of some kind or whatever so that we know, and the doctors, when we get there, he can see exactly what we are there for and what he is supposed to check as a follow-up. Somebody has to step in, right? It's actually the most effective safety mechanism that we have currently. You know, it's not computers, it comes right down to people. Somebody being there that can question things. So when patients have complex needs involving multiple specialists, the systems often default to the family to act as that EHR person to bridge the gaps. The fix isn't more hospitals, portals, and things like that. This is what drives me crazy. We don't need 10 different logins and 10 different portals scattered all over everywhere. We need a system where the patient owns the data, right? Personal health operating system, if you will. It follows you, the patient, not the building, not the hospital, not the clinic. It follows you. Until we stop treating the medical records like a trade, like a trade secret kind of a thing, and start treating it like it's a universal utility. The communication gap will remain the most dangerous room in the hospital. But here's some changes coming up, and here's what's happening in 2026. A lot of this will help solve the exact problem that my wife's had a couple of times. One of them is what they call Kill the Clipboard initiative. There's a major federal push led by CMS, specifically nicknamed Kill the Clipboard. The goal is to ensure that medical records follow the patient, not the hospital, not the clinic, not the doctor's office. So how it works is instead of logging into 5 different portals to find a lab result, the data is pushed out of the hospital silos into a single app of your choice. I'm not sure if you've heard of this or not, but you should check it out if you haven't. And when you go to a new specialist, you don't have to fill out 1 million pages of paperwork and wait for 2 or 3 days for them to transfer all your information. You can simply share the records instantly via a secure link or a QR code from your own device. You might start hearing about this. The term is TEFCA, or Trusted Exchange Framework and Common Agreement. Think of it like an ATM network for healthcare. Just like you can use a Wells Fargo card at a Chase ATM, the TEFCA is a national network that allows different hospital systems, different kind, wherever you're at, or independent clinics to securely talk to each other and get your medical data. By early 2026, nearly 500 million health records were already being exchanged through this network. It allows a patient-owned app to pull records from every doctor your wife has seen in the past, even if you've forgotten the name of the clinic. Companies like Samsung and Apple have partnered with health tech platforms like BeWell to turn your smartphone into the front door of your health system. These apps aggregate your medications, surgical history, and lab results into one timeline, sharing with doctors. In some newer systems, when you check in at a doctor's office, their system can automatically update your health insurance, called a handshake, if you will. That just goes right, they can tap right into your phone app and update your records, rather than relying on a fax machine, which, man, I can't even believe we're talking fax machines in our modern system with healthcare and stuff. The government has recently started cracking down on hospitals that make it different for patients to get their own data. Under new rules, if a hospital purposely makes it hard for you to move your data to your own personal app, they can face significant penalties. So if your wife or whoever has an iPhone or an Android or something, they can just go into the health apps part on your phone, and there's a feature called Health Records. You can search for her specific or your person's specific hospitals, like Intermountain Hospital or wherever, and link to them. Once you're linked, the phone will automatically pull her labs, medications, vitals into one single list that you can show to a primary care physician during those hold-up moments, if you will. So the next time you're at a follow-up, don't assume the doctor has read all the notes. Ask them about it. Have them show you the information on the screen if you need to, because it's a system that's fragmented. Your voice is the only thing that actually connects the dots sometimes. So here's kind of the plan we've been using last 2 days before her appointment with specialists, mostly. But we don't just call and confirm the time. She does that too to make sure you got it right. But we ask specific questions like, I'm calling to verify that Dr. So-and-so has received my surgical notes, or he has received these certain tests, or whatever it happens to be. Can you check your files to see if they are there? See, often the front desk doesn't realize that the fax or the digital transfer is missing unless you call them. And if you call them and they don't see them, then they have 48 hours to find them before you're sitting at the exam table wasting your 15-minute slot so they could find them. Also, many of these portals, I know my wife has it on several of hers, they have a message my provider feature. So 48 hours before, she can send a brief message straight to her specialist. Sometimes they don't answer them all personally, but some of her doctors have actually answered them back personally. And we just say, hey, I want to ensure that you've had a chance to review this stuff. Same thing. I had an appointment recently where I had the same incident for me. I have diabetes, and so I take a diabetes medication. And I needed a refill, but it had been about 6 months, so they required that I come in, have my A1C tested, and that kind of stuff. So when I talked to the gal at the desk, I said, well, if we're going to have to do that, why don't we plan and do my annual wellness check? And so if you want to get the doctor, send the orders over to the hospital lab. I can get all the blood work done there, and then when I get in, we'll just set the appointment, the actual appointment 2 days after that, so we knew they had plenty of time to get all that stuff done. Okay, so everything's great. So I get into my appointment, I check in at the front desk there, and I remind the receptionist there that I already had all the blood work done. I know it was done because it was in my patient portal, to make sure the doctor was aware of it. Problem was, when I got into the room, the doctor comes and asks me how I'm doing and stuff like that. And then he has a new nurse practitioner that's going to be working out of his office, and so they introduce and do all that kind of stuff. And then he asks me, are you ready to go get some blood drawn? And I go, dude, I already did that 2 days ago. I already set up with your office here. I talked to your receptionist when I came in. Said that you should have them, and that make sure you got them. But they hadn't made sure that they printed them out and let him know that. Truth is, by the time they messed around and he was able to get it into a computer and see them, we pretty much ran out of time. So he asked me a couple of quick questions, so I didn't get much of a visit out of it because of that, and I was a little disappointed, to say the least. But these things do happen. So I should have taken my own advice, the stuff I've been doing for my wife, and I should have maybe even called as soon as I knew that those reports were, those test results were in, and made a call. But I figured just 2 days away, and I already talked. I don't know. No matter how hard you try, it just doesn't always work. But you have to ask questions. The other thing that we have done, and we mentioned a few minutes ago, we create a one-page document of some kind with all of what the visit's about, anything that he needs to check and anything that he needs to review, and list the doctor's name, all of the information about what he's supposed to be doing. Even in the modern systems here, this is why that we have failures. A busy primary care office could get 100 or 200 notifications a day in their inbox, right? If the surgeon or whoever didn't make a specific note and CC a copy to your primary care, it might just be sitting in the general hospital database somewhere, and they never did see it. We seen earlier about 50% of the time the specialists don't notify the doctors. Hospitals often use hospitalists and discharge patients. That's exactly what we seen at one time with my wife. These doctors may have never met your wife before, which they hadn't. They didn't know your PCP. So, they're just going basically what's written on a page. So, like I said, make sure you have an accurate list of all your medicines and all of this kind of stuff so you can talk with them and make sure that they have it correct. My wife had one other incident here, too, that I might mention, because this has happened more than once, but this is a recent one. She was at one of her specialists. I can't remember even what it was for because she has quite a few of them. But anyway, she was on a medication for something, and they thought it wasn't working quite as good as it should for her, so they changed to a different type of medication. Okay, so that's great, no problem, you think. But then about 6 weeks later, we got to her kidney doctor, her specialist. And of course, I had my sheet that I always bring with the current list of her medications, and he was reviewing that, and he said, well, wait a minute, how about this medication? And so then we went through the story. Hey, well, they took her off of that and put her on this one over here. And he said, well, I really wish they would let me know that, because he said that medication was working for what that other physician specialist had in mind, but it also had beneficial effects for her kidneys. So he said, I was depending on that one to kind of help keep your kidneys in shape. So he said, now we need to make sure we watch and check this really close to make sure that your kidneys aren't going to backslide, because she'd had some serious issues and she had made significant improvement. But these are the things that I'm talking about. It happens all the time. You have to be careful about it. So anyway, right this minute, I think that's about enough. But I have a couple of little quotes here that I thought might be kind of interesting before we go. And the one quote is by Sir William Osler. It said, the good physician treats the disease. The great physician treats the patient who has the disease. And just one more for fun. This is from Mark Twain. He said, be careful about reading health books. One day you might die of a misprint. I thought that was kind of humorous, but kind of spot on too. So anyway, I'll leave that with you. I thank you very much for joining me today. I hope you found it entertaining, educational, or thought-provoking. Join me next time, won't you? I'm Craig Warren. This has been the Ramblings of an Old Fart podcast. God bless and keep you. Till next time.